Good evening, everyone, and thank you so much for joining us tonight. My name is Nicola Willier-Fenton, and I'm with University of Vermont's Continuing and Distance Education Department. And we have an excellent panel tonight talking about how we reopen America and Vermont and our surrounding areas safely, with keeping an eye on protecting ourselves, our family, and our community. I want to do a quick introduction of our panelists this evening. We have Dr. Jan Carney joining us. Jan Carney is an Associate Dean for the Public Health and Health Policy at Robert Larner College of Medicine, our Professor of Medicine and Director of Graduate Public Health Programs at Larner, and also the former Commissioner of Health for the state of Vermont. We're so thankful to have Dr. Carney on our team tonight. We are also very fortunate to be joined by Dr. Patsy Kelso, also with the Vermont Department of Health, our state epidemiologist, areas of expertise, epidemiology, applied health, and infectious diseases. Thank you, Dr. Kelso, for joining us this evening as well. As I mentioned, just some brief introductions, and then we have a full agenda tonight. I will briefly go over the topics before Dr. Carney dives in. What is the status of the COVID-19 pandemic globally and nationally? What can we learn from past pandemics and outbreaks that will help us today and as we go forward? What is a potential second wave? And what are the trends in Vermont since the pandemic began? What measures are the Vermont Department of Health monitoring? Dr. Kelso will walk us through those measures that she's been keeping a very close eye on in the Department of Health. What do experts recommend as we reopen to protect public health? And why hand washing, physical distancing, and cloth face coverings are important, and how we can continue our public health and our public safety by continuing some of those different methods. We also have lots of links throughout the presentation. We will record tonight's presentation, and we will share the recording with the links to everyone who has joined us this evening as well. As I had mentioned in the chat box right before we started on YouTube, that please post any questions there. I'll do my best to monitor those questions and then ask Dr. Carney and Dr. Kelso to help us with those questions tonight. So Dr. Carney, this is the third time that we've had the chance to have a webinar to help inform the community of the coronavirus pandemic that was happening right from the beginning, and then the science of social distancing. You always come back to the science. And so I wanted to just lead with that tonight and have you walk us through what is happening right now since we've spoken a few months ago on this topic, and where are we going forward. Dr. Carney?
Hey, thank you very much, Nicole. And yes, we're going to look at the science and some, I hope, interesting studies here. But this is from the Johns Hopkins School of Public Health, and this is just the global map of where we are now. And you can see the total is over 6 million cases and more than 375,000 deaths. And we know they're spread all over the globe and getting worse and better in different places in our country and the world. Next slide, please. And you can just see this now since the middle of March to the current time. And that top line is the United States. And we see sort of a general overall decline, but we know that varies state to state. Some of the other countries you might see is that orange line is the United Kingdom. And they're recently declining, but they've had a substantial burden. Next slide, please. And this is from the US CDC. And unfortunately, in the end of May 28th, our death toll surpassed 100,000 deaths in our country. And again, we don't see that this is uniform across the United States. We've been extraordinarily fortunate, and that is not a coincidence. You're going to hear more about that, but our flattening the curve and all the efforts that have gone on between the Vermont Department of Health and the UVM Health Network and Medical Center, the University of Vermont, I think have helped a tremendous amount. But you can see the variation across the country. Next slide. I saw this in the Washington Post on that May 28th as we saw 100,000 deaths across our country. And the rays of light are brighter in the places where more people have died. But this map just really resonated with me. And the quote that talked about the pandemic has exposed the nation's vulnerabilities and dangerous divide. And I'm reminded with the health inequities across our country as an example For African American and Black Americans in Louisiana, they're about 30% of the population, but about 55% of the deaths. And in Washington, D.C., Blacks and African American people are about 45% of the population, but about 3/4 of the deaths. So we have across the country and states and different counties and communities tremendous health inequities. And we'll touch again on that later in the program. Next slide. So what can we learn, back to the science, what can we learn from past pandemics and outbreaks in different parts of the world that might help us right now in the moment as we're talking about our new normal and what we're doing in the reopening? Next slide. So the first I want to show you a little bit from, this is a great source, and this is the Center for Infectious Disease Research and Policy, and from the University of Minnesota. And they put together a series of very easy to read reports, and you can go and read them yourself. And the one I want to talk about just for a minute is the future of the COVID-19 pandemic, lessons learned from pandemic influenza. Next slide, please. But before I do that, I just want to introduce the concept of the basic reproduction number, or R naught, because you may hear that, you'll see this in some of the articles, and it's commonly misunderstood. And this is the basic reproduction number describes the contagiousness or transmissibility of infectious agents. But the misperception is that this is just properties of the virus itself. It's in part, it can also be impacted by our behaviors and our geography and what our environmental distancing is like, as an example. So what that means is, like, if there is an R naught of 2, and on average, for every infected person, we'll spread it to 2 other people. Next slide, please. All right. So through this infectious disease and research and policy center, what they've concluded in this recent article is that because of a longer incubation period, more asymptomatic spread, and we're going to talk about masking, this asymptomatic spread really is important, and a higher R naught, COVID-19 appears to spread more easily than the flu, more contagious and more easily than the flu. So a higher R naught means that more people will need to get infected and become immune before the pandemic begins. What can we compare this to? The normal seasonal flu, not the pandemic flu, might have an estimated R naught of about 1.3. So for every person, you might spread it to just a little bit more than one person. And when that R naught is over 1, that means that you're going to continue to see an increase of infection. Some of the studies have published an R naught for COVID-19 of in the range of 2.5, but that can vary depending what you look at. So let's see, based on the most recent flu pandemics, they estimate that the pandemic will last 18 to 24 months. People do not really know. These are expert opinions and research reports. And it won't be halted until 60% to 70% of the population is immune. And that is that at least 60% immunity is related to the herd immunity that I'll talk about in a second, but that's something that a lot of people are talking about. And then also depending on the control measures that may come in waves. I'll show you some examples of possible scenarios in the next slide. So down at the bottom, you can see that we start with that first, on the left side is January, then July, and then next January 2021. And here's some of the possible scenarios. First scenario is peaks and valleys. We see an increase in COVID-19 cases like we've seen, and then it dips down, and then we see some more again at different time periods. Another possible scenario is a larger peak in the fall. And then the third one is just kind of slowly, we continue to see small rises and falls that happens over time. So let's talk for a moment about that herd immunity. As I just mentioned, some experts and a lot of experts are saying at least 60% of the population will need to be immune for the pandemic and the infection rate to really, really slow down. And that's based on that basic reproduction number that I just talked about. So why is that important? And I'll show you some of the numbers. And this is from a recent, excellent article from the New York Times that looked at some of these across our country and across the globe where people have done different things. You can look at New York City where about 20% have antibodies now to COVID-19. And then you contrast that to London, 17.5%, and Madrid. Wuhan, China, the returning workers, about 10% had antibodies to COVID-19. And you can see Boston and Stockholm and Barcelona. One of the things that was important in this is there was a bit of a debate about do we do all the social distancing that we learned that worked really well in our country in the pandemic flu of 1918, or do we let nature take its course and develop this natural immunity? So places like the United Kingdom started out that way, and then they got a report from the Imperial College that really warned them that they better do some shutting down because their death rate might in fact be higher. Other places like Sweden decided to take minimal restrictions as compared to us. And in fact, they only found in places about 7.3% had detectable antibodies or evidence of some level of immunity, though we don't understand that. But their death rate was on the order of 9%. What this tells us in total is that even if we take very few restrictions and let nature take its course, we won't develop the level of population immunity that we need to get that herd immunity altogether. So, next slide, please. We need a vaccine. And the good news is that there are a lot of vaccines currently being tested. The World Health Organization today put out a report that said there's probably at least 100 clinical trials going on. Their investigators are trying all different kinds of strategies in addition to the ways we've always made vaccines. And as a matter of fact, in the Lancet, a very prestigious medical journal, the results of a recent phase 1 trial looking at one of these vaccines. Phase 1 means they'll look at the toxicity, side effects that were similar to some of the vaccines that are in common use. They did find a high level of antibody production. That's great news. So these studies are going on. We're reading about them every day and every week. And we desperately do need a vaccine for COVID-19. Next slide, please. So this is just a reminder for me to tell you that the National Institutes of Health website is an excellent source of high quality, evidence-based information, all the cutting edge science. And if you look there, you can also see information for the public that takes you right back to the CDC website, which is another place that I recommend that we go for information. Next slide, please. So I want to talk about a couple of interesting studies that I think are really relevant to some of the things we're talking about in this conversation about how do we reopen safely? What things are we talking about? So this was an outbreak associated with air conditioning in a restaurant in Guangzhou, China, in January and February of this year. And they were investigating an outbreak of 10 people who got COVID from 3 different families. And they linked this to some of the air conditioning in a room with no windows. So I'm going to show you a diagram of their investigation. Next slide, please. So here they are, and they're the red circle, it says January 24th, it says A1, that's the first person got ill. And then all the other red circles were the other people who became ill. Now this just shows 5 tables, but there are actually 15 tables in this restaurant. And on the right side, you can see the air conditioning. The air is blowing to the left side, and then it comes back again to the right. And so what the investigators concluded, because none of these people who became infected had any other exposures except for this person called A1 in this diagram, that indeed the droplet spread. And we had a room that had no windows, was closely contained. The tables were very, very close together, and they reinforced the importance of ventilation and spacing people apart. Next slide. All right, the second example I want to give you is about an outbreak in a call center in South Korea. And there was this very big office building, 19 floors in an urban area in Seoul, Korea. And on March the 8th, there was the beginning of an outbreak. And what was notable, what shows on this is the epidemic curve, and the higher the curve, you can see when the cases were detected. They actually closed the building on the 9th of March, the day after it was reported, and they looked at the ventilation system. But these workers were working in a call center. So they were sitting around, they're the ones talking on the phone, like all day long, sitting in close proximity. They worked on 3 different floors, and you can see then the green is the 9th floor, the yellow is the 10th floor, and the blue is the 11th floor. And you can see that most of the people with the cases, they tested over 1,000 people, and they found that there were 97 cases diagnosed of COVID, and of those, 94 were on the 11th floor. So I'm going to show you the next slide because it shows one of the things that they learned that I think is very relevant to today is see this blue on the top of the screen. In the middle is the elevators and the stairs, and on the blue is where people were sitting. And 94 of those 97 were on this floor, and the vast majority were closely clustered in one very dense office space on the 11th floor of this building. Just a handful of people every place else. Even though these people went back and forth and they went in the break rooms and the elevators, this was really, really important.
Dr. Carney, I just want to ask a question because this slide is so interesting to me and this study is so interesting to me because we all know workspaces like this. Maybe we're not all in environments that are that large with that many people in open spaces, but we can certainly compare to our own workspaces in many circumstances. So many people, I'm sure, are wondering, well, what does this look like then going forward? Are there dividers? Are spaces when we come back into workspaces as people transition back in, are they going to look different? And is that realistic for employees to be asking for that?
That's what I mean. Those are some of the things that people are talking about. What does the new normal look like? We're going to be talking about physical distancing, reducing the density of people, the ventilation in buildings. I don't expect that the desks will be that close together, as an example. And we're also going to talk about masks because think about this call center and people are sitting there in close together and this talking and for many, many hours of the day. So we're going to come back and touch on some of those considerations, which are people are talking about for workplaces, working remotely as we've been working, as many of us have been working for the past couple of months, and some other things.
Yeah.
This is a reminder for me to mention again that some of what we've learned that has been highly effective in many places of the country, and specifically in Vermont, from interventions, they call them non-pharmaceutical interventions. What does that mean? It means anything that you do, it's not a medication or a vaccine. And from the 1918 influenza pandemic, those things like we have done here in Vermont, where we reduce the density of people. That's a large, postponing large public gatherings, closing schools temporarily, those kinds of things, or stay at home, stay safe. Those kinds of things were very effective way back then, as evidenced by reduced death rates in the geographic areas that actually did that. So I want to continue on with our just another emphasis about community mitigation and some of these different general categories of non-pharmaceutical interventions. I won't use that term anymore. We'll call them by what they are. But there's 3 general strategies, and these again are very relevant as we consider our reopening and our new normal. The personal, staying home if you're sick, people still will need to do that. And covering our coughs and sneezes, washing our hands often, and wearing a cloth face covering. The cloth face covering is something that is a newer part of the discussion, and I'm going to talk about that a little more in just a second. So at the community level, creating spaces between people, that physical distancing, that's the 6 feet apart. That might be looking at how our classrooms and workplaces are organized in terms of where people are and how many people are there. We've already talked about how we've temporarily closed the schools and restricting gathering sizes, not having large crowds of people together, and then cleaning frequently touched objects like our cell phones. Okay, next slide. This was from the end of March, where the NIH said that there was evidence about how long coronavirus really lived on surfaces, environmental surfaces, maybe as long as 3 days on plastic and stainless steel. And that was the rationale for making sure that we have our frequently touched surfaces clean and we're washing our hands. But by and large, the most important from CDC is the importance of that respiratory droplet spread. So that leads us to some of our discussion about remaining socially apart, physically apart, that social distancing. It's 6 feet apart. And that's something that we'll continue to need to remember. So, cloth face coverings. Let's just spend a minute on this. And sometimes they're called cloth face masks, but those are very different from medical masks. And medical masks are these surgical masks and these N95 respirators that you wear in healthcare settings, and they were in short supply. So really, for many reasons, medical masks are worn by healthcare professionals, and we're talking about cloth face coverings for the general public for in most times that we're out in where there might be other people there. So COVID-19 spreads through respiratory droplets, and that's a really important way of spread. Coughing, sneezing, and talking usually travels about 6 feet. It's not an absolute, but that's what we consider a pretty safe distance. Sometimes people don't have symptoms, and asymptomatic spread is something that has been documented. So that's another part of the rationale. And if everyone wears cloth face coverings, they can slow the virus spread. The cloth face covering may not protect the wearer, but it protects the wearer from spreading it to others. So if I wear a cloth face covering, I protect you, and when you wear it, you protect me. So I do want to show you, because we think mostly about coughing and sneezing, but they did this very interesting study with laser light, and they had somebody who was saying for about 25 seconds at a time, they kept repeating the phrase, "Stay healthy," in a very loud voice. And what you see on the right is that laser light showing, and all those green areas are the droplets that they could actually see with the light. And on the left, they plotted how long till you couldn't really detect those droplets in the light anymore. And it was sometimes between 8 and 14 minutes. So what that tells us is that, again, you can have that droplet spread out in the air, that if you're becoming ill or you are one of those asymptomatic people, that you can do that through normal talking over a prolonged period of time. So let's talk about just another minute about the masks and COVID-19. And this, I really like this graphic that was from the Journal of the American Medical Association patient page. And so the most important things are to remember that social distancing and good hand hygiene are the most important things. And then by wearing masks in public, we can further limit the spread of COVID-19 in our communities. So what this says is sort of, here's the steps of how to put on your mask properly and take it off. Wash your hands first and put the mask behind your ears or your head without touching your face. And then make sure that it's comfortable, not too tight, so that it doesn't restrict your breathing. Not too loose, not too tight. And you may have to experiment a little to find the design of mask that's comfortable for you and get used to that a little bit. And then try not to touch your face while you're wearing it. And then when you take it off from behind your ears, and then wash your hands again. And then make sure that you are washing. You probably need several of these, and you're going to have to wash these on a regular basis to keep them clean as well. And that's something that we've added to the recommendations, and I think will be an important consideration as we go back to our new normal and our gradual reopening. So I'm going to stop there, Nicole.
Thank you so much, Dr. Carney. I just want to pause before we start hearing from Dr. Kelso. This is such an important slide because we're seeing such a mix out in the community. People are wearing them, they're not wearing them. People are curious, do I wear them when I exercise? Do I need to wear them when I go for a walk? So many different questions and age ranges as our early childhood education centers are starting to open up. What are some of the responses to those kinds of questions? The age range, helping children by modeling some of this activity, and then what is the recommendation for exercising? Are people expected to wear them when they're out walking, or should they be?
They're not recommended. Well, first, let me just say that I think this is a bit of a culture change for us. We see this in other cultures already, right? When you see pictures, and when we saw that pictures from different parts in Asia, you would see people wearing those during their normal life, and that's. I think we're experiencing a bit of a culture shift now. They're not recommended for children under 2, and in terms of getting used to that and finding one that feels comfortable for you when we're out in public. If you're out walking, if you're walking in an area where you come in contact with, or you're passing a lot of people and you're not really that distant, it might make sense to wear one. If you're out in the middle of nowhere in Vermont and you're running, I would say you can probably safely go without. And and so I think that again, it's something that we all have to get used to and comfortable with and find some. I know I now have my personal favorites. My daughter made me one that has a cow print, and I love it. And that's my favorite, but we all need to find our way here.
Great. Thank you so much. I know lots of people are trying to figure out what's the best method for themselves and their family members, and how often. I've just found that having several in the car and several in my bag kind of cover the basis so that if I am out and about, I make sure that I have them. Thank you, Dr. Carney. We'll come back around to you with some more questions as well. I'd like to also, Dr. Kelso, thank you so much for turning on your microphone and joining us tonight. I can only imagine what an incredibly busy time this has been for you and the team at the Vermont Department of Health. So thank you for everything that you have all done to help keep our community safe and guide us down the path that many Vermonters have been taking to ensure that our statistics are very low here in the state. I'd like to just toss over to you and to kind of give us a grounding again as to what has been happening in Vermont and how we do move forward.
Sure. Thanks for having me. And thanks for your kind words. We're certainly very busy, and it takes a team, and I'm so proud to work at the health department with the great people there. So we're going to look at the data going back to our first case that was reported on March 7th. And the orange line here shows that our most recent data as of yesterday was 988 cumulative cases since March 7th in Vermont among Vermont residents. And so that's that line that, you see the big increase in the later part of March and into April. And then our growth rate has certainly slowed, but continues to creep up. Those blue bars underneath, which we can see better here when we get rid of that orange line, are the dates that the cases were reported to the health department. So going back, the one case on March 7th, then we had our second case on March 11th, and then we had a pretty big increase in our curve with 70 cases reported in one day back in early April. And luckily, we've declined since then. And the last several weeks, we've really seen a very small number of cases each day, just a handful typically of new cases reported to the health department each day. The darker blue lines are the dates of deaths among Vermont residents. This is our epidemic curve, or our epi curve. The previous slide with the blue bars represented the dates the cases were reported to the health department, but traditionally an epi curve is reported by date of onset of the case. So the time frame is shifted a little bit in this one, but the curve looks very similar. These are the onset dates of our cases. So going back to March 5th was the first onset. And at the right side of that graph, you'll see the shaded in area. there's about a 6-day lag between when a case first becomes symptomatic, then they might see their healthcare provider, get referred for a test. We'll wait a day or two for test results to come back. And so there's about a 6-day lag between that. So we're not 100% sure that we have that number of cases in the most recent days. So we put that gray shading. And I find this chart really helpful. It helps me understand the bigger picture of what's been happening in Vermont. Those familiar blue bars are very tiny here. Those are our positive cases. The gray and red colored bars are the numbers of laboratory tests done each day going back to March. And you can see that we typically have many fewer laboratory tests submitted on Saturdays and Sundays. Those are where the bars dip down and then come back up again for the weekdays. And you'll also notice that in recent weeks, we have increased our testing significantly. We're testing many more Vermonters, close to 1,000 a day in that range. The, if we could go back, the blue line represents the percent of all the tests done in a certain day that were positive. And while we were at the peak of our outbreak in Vermont, where those blue bars are, you could see that the percent positive was up around 10% for several days. And since then, as our cases have declined, our percent of positive tests has also declined. So we're keeping a close eye on that. This is one of the other indicators we're looking at. It's syndromic surveillance data, which was developed for flu surveillance season. We use it every year looking at our influenza rates. And it's the percent of people who are presenting to an emergency department complaining of flu-like illness, so fever and cough, for example. And the flu data is on this in the darker blue line. And you can see that in March, and then as we got into April, that was on the decline as flu season typically wraps up around that time of year. And around that same time, we were starting to see an increase in COVID-like illness. So symptoms, people presenting to an emergency department with symptoms that might be COVID-19. These are not lab confirmed tests. It's just meant to give us an indication of what's happening in the community. And we're keeping a close eye on this data too. It's one of the metrics we look at every day. We want that to remain below about 4% of visits to emergency departments. We think that's a relatively safe range to be in, and we've been there for a few weeks now. I wanted to shift to talk a little bit about the symptoms of what we're seeing in Vermont. And people may remember that when we first started hearing about COVID-19, we were talking about 3 things: fever, cough, and shortness of breath. And then as we got more data and information on more cases of this brand new virus that no one knew before the end of 2019, we realized that it's not just those 3 symptoms, but there are other symptoms that are pretty commonly associated with this disease. So they include fever, cough, and shortness of breath, but also things like muscle pain and a new loss of smell or taste, loss of appetite, chills, other symptoms. So this represents, most of our cases in Vermont have had cough and fatigue and headache and fever and muscle pain, but these other symptoms are fairly common as well. We don't expect that list of symptoms will grow. There's, worldwide, there have been so many cases, and we've gotten a lot more data, and so we don't expect that list of symptoms to increase significantly again. We expected, and it's shown to be true, that older Vermonters are disproportionately impacted by COVID-19. They're more susceptible to severe illness. So these are the rates in different age groups per 10,000 Vermonters. And people 80 and older certainly have the highest rates of illness in Vermont, as we've seen in other states. Mm-hmm. And similarly, older adults are also more likely to be hospitalized. We have, as of this data, which I think was from Friday, 121 of our Vermont cases had been hospitalized, and 760 were not hospitalized. But the people who are hospitalized, again, are the older people, people 70 and older. Of those Vermonters who are hospitalized, about 17% have been put on a ventilator and 37% have been in the intensive care unit. And the average length of stay in the hospital for these patients is about 8 days.
Interesting.
As Dr. Carney said, there are certainly health disparities in America, and I felt like it was important to show this slide that while the vast majority of our cases in Vermont have been among white Vermonters, African American Vermonters have the highest rates when we look at the rate per 10,000 Vermonters. So on the right side of the slide, you can see that there are about 26 cases per 10,000 African American Vermonters, while there are only about 13 or 14 per 10,000 among white Vermonters. And this epi curve breaks out our cases in the gray bars as what we call sporadic or individual cases, not tied to any cluster or outbreak. And then the blue bars are cases that have been associated with outbreaks. And we've seen outbreaks in Vermont in long-term care facilities and similar settings, in correctional facilities, in household clusters, and in other groups. So we also think it's important as we strive to protect the most vulnerable Vermonters to keep a close eye on where we're having outbreaks occurring. I want to wrap up just by talking about the contact tracing that the health department is really engaged in now. We have about 50 people fully trained up and a few dozen more who we can bring in if we need them. Hopefully we won't. And what contact tracers do is reach out to every positive case that's reported to the health department, and we interview them with lots of questions just to help them remember where they spent time and who they were with during the period when they were contagious. And we inform the case that they need to stay home and isolate and stay away from other people until their symptoms have resolved, and it's been 10 days since their symptom onset. And then we enroll them in this new app that we're using called Sarah Alert. Enrollment is voluntary. They don't need to participate, but by enrolling cases, we can be in touch with them every day through the method that they choose, whether it's a text or a phone call or an email, just to check in on their symptoms, see if their symptoms are getting worse, and if they might need to seek health care, or if their symptoms are resolving. Then we take the information that we got from those cases about who their close contacts were, and we reach out to each of those close contacts, and we advise them that they were potentially exposed to a case of COVID-19, and we tell them the quarantine guidance that's appropriate for them to stay home and away from others until 14 days after their last exposure to the case. And we also can enroll those people in Sarah Alert so that they get a different message every day, checking in to see if they are developing any symptoms that could be due to COVID-19. So it's a great way for us to really be in touch with people, whether they're a case and we're doing symptom monitoring, or whether they're a contact of a case and we're checking in to see if they're developing symptoms through this electronic system that doesn't track them at all. It's not some of the things we've heard about in the media that does location tracking or identifies people they've been near. It's not that at all. It's just a way for us to be in touch with them every day.
Great, thank you for that definition. I think that's really helpful for people to understand what that is. Do you anticipate as we open up again here in Vermont that there'll be a need for more contact tracers? Are you kind of staffing up in this area, or do you feel like you guys are in a pretty good spot?
We are in a good spot right now. We have plenty of people to do the work currently with our low number of cases, but we do expect that as we open up Vermont and as we allow larger gathering sizes and open things like schools in the fall and childcare this week, that we do anticipate we'll see an increase in cases. going to be unavoidable to some extent as we reopen. So it's important that people continue to do social distancing and wear cloth face coverings because, um, as we reopen, we're at more risk.
And I think too, it's such an interesting time to think about how important it is to continue to do the things that we've been doing, because now we're exposing more again. But it's an interesting time because I feel like people are also battling, quarantine fatigue, that they've been doing this for several months, and how much longer do I have to keep doing this? So how do we as the public and the community kind of wrestle with those challenges that I know that everybody's having, because we're being asked, of course, to continue this kind of thing. But when you step out sometimes into the community, you see that's not consistent. And so I'm just curious as to the kinds of conversations, from the Department of Health as to how we can stay grounded in that we're doing this, especially now as things start to open back up again.
Yeah, it's hard. This quarantine is hard, and we should remind ourselves that we haven't done anything like this in the world or in the United States for 100 years. The last time we had restrictions like this on social gathering on a large scale were in the 1918 influenza pandemic. So we're not used to this, and it's hard, and everybody's having to adjust to homeschooling their children or teleworking and staring at a computer all day instead of meeting with people face to face. It's important though, because this virus is still around and there's not a vaccine. And the only things that we can do are community mitigation or non-pharmaceutical interventions that Dr. Carney talked about. So staying away from each other, using facial coverings. And then at some point, hopefully when there's a vaccine, that will help us restart. But in the meantime, we need to take it slow.
Absolutely. And Dr. Carney, I'm going to come back to you too, because I think a lot about, just before we get back into some of these numbers here with Dr. Kelso, you mentioned that there's a couple different scenarios, and one of the scenarios could be that fall we get another big spike, and there's a lot of discussion about that. And then you start seeing images in other countries where some schools have opened up again, and there's, physical distancing with the students, barriers in the lunchrooms, and they're walking down the hallway in certain lines, and as parents we struggle with, is that the right, how do we do that knowing that this is for the best for our public health, but also wrestling with how do we do that and help our children to understand how to enter back into these kinds of situations. What are some of your thoughts on that? And maybe Dr. Kelso, maybe the conversations that you might be having in the health department around this too.
Available science, and they're doing it carefully. And the kinds of things to monitor, and you're going to hear about the monitoring a little bit more, and watching very, very carefully. Some of the things that I just showed you, the principles, I think we know that the principles from past pandemics work, and how we apply them, and the rationale to apply them. When it gets really hard and to be patient, you have to remember that it's going to help us. And so there's no easy way. I think we just have to do it carefully.
Take our time, I think, as Dr. Kelso said, to go slowly. Dr. Kelso, do you want to go back through just some of the other information, the early detection and the reporting metrics that you are keeping a very close eye on as well?
Sure, just a few slides to share some of the things that we are looking at every day at the health department and across state government. So we're looking at our ability to do case investigations quickly, to identify close contacts and get them into quarantine. I think these slides speak for themselves. I won't read them. If we could just go to the next one. Making sure that we are monitoring people for the full 14-day incubation period, that if contacts of cases develop symptoms, that they have access and ability to get a test to identify whether they've become a case. We're using Sarah Alert to keep keep track of the number of cases and contacts we have, and hope to assure ourselves that we're on top of all these potential situations so that they don't expand into additional cases. And then we're looking closely at our testing numbers, not only the number of tests we're able to do, but the percent positive. And this says our target is less than 8%, but as I indicated before, if that gets to, 4 or 6%, I think we'll be taking a close look at whether we need to think about more community mitigation measures again. And just looking at our case rates, our percent positive, whether we're having outbreaks in facilities, all of these things we're looking at every day just to make sure we're on top of the data and using the data to inform how we restart Vermont. So the Centers for Disease Control and Prevention has come out with a handful of metrics that they feel are really important for whether states should start reopening society. And those are some of the things we've already talked about, the COVID-like illness presenting at the emergency department and the percent of cases that are positive, percent of lab tests that are positive, and the case growth rate over a 14-day period. So we're looking at those, using that data to inform all the state agencies and discussions about reopening school and how to do that, and when to reopen childcare and restaurants, and all of the things that we're starting to see. And the governor has been really transparent. I think we're lucky in Vermont with his 3 times a week press briefings and providing information on where we are and what's coming next as we reopen Vermont.
Absolutely, that I have found that information so incredibly valuable. Dr. Carney, I want to come back to you as well, because I know that you have exposure to other public health officials all over the country, and conversations that are happening across the United States as to how we do this effectively. What do you think has made such a difference here in Vermont as you see and hear of things happening in other parts of the country? What do you think we have done well here, and what do you think we need to maybe improve on?
I think we are very fortunate to have a really, really great Department of Health. And Dr. Kelso works with the CDC and other state epidemiologists, and they have their finger on the pulse of what's happening in areas that aren't doing so well. I think that's one really important thing. The other thing I think we do well is I think we work together very well, so that the University of Vermont Medical Center and Health Network and the University of Vermont and our Larner College of Medicine and the Health Department are all working together to bring any expertise we have in any of these different areas to bear on everything that's happening right here in Vermont, what we need to do next, and on. So I think we do that great. And I do feel that we're so very fortunate to be here and to be able to have that expertise, and that people are transparent and they communicate with each other, and that all the work is really for the benefit of all the people who live here. And I think we can be really proud of that. I look around, there's tremendous variation what's going on in the other states. And you can see, and the pictures from Memorial Day weekend were horrible. And people were just ignoring all the advice and sometimes all the governor's orders. And we also see that their disease rates haven't plummeted like ours have. And so they're not seeing the same thing. I am very confident that what we are doing is the right thing, and the people working here on our behalf in Vermont are doing everything they can and should be in this place right now. And I guess I have that same expectation for going forward as we're reopening. And there is an element of the unknown here, and watching that very carefully and communicating and putting all that information on the website so that people can see for themselves. I think all of that is very, very important here.
Great. Thank you for that perspective. I do want to come back to a couple questions that have come through to our audience on YouTube. from our audience on YouTube. And this is an interesting question. I suspect either one of you may get this very often, but maybe Dr. Carney will continue with you. Can you get the virus twice? There was a comment that was made, or have you gotten it and you are immune to it? Or if you've gotten it, are you immune to it? And I don't know that we know the answer to that yet, do we?
I certainly don't know the answer. I don't think, I'll ask Dr. Kelso, she knows the answer, but I don't think we know the answer to that. One of the big things we don't know is about the immunity. You know, how immune you are if you've had the infection and how long that lasts. And I think both those things are extremely important moving forward. So that's a very long-winded, I don't know.
Right. Well, your honesty, we always appreciate. And let's go back to the R naught rate, because that was an interesting point that you made before, and some clarification and definition. And we had a question from earlier in the presentation saying, how directly does the R rate affect the percentage for achieving herd immunity?
I think what you can do, and it's a calculation, and I am definitely not the one to go through the math class tonight. But I will tell you that, let me just give you it gives you a sense of, and again, it's in part due to the virus itself, but also these other factors can influence it. And it's this transmissibility. It gives you an idea of how much of the population must be immune for us to see that herd immunity or that protection in the population. As an example, measles has an R naught of over 10, highly contagious. So what that means is you need a very, very high vaccination rate in the case of measles in order to protect the population. So that's about, and again, I want to be careful. There's a lot of confusion about that. And it's not a simple concept in my mind, and it can be easily misused, but that's as best I understand it.
And then going back to a question related to, and I know the three of us, when we were discussing some of the content for tonight, the mask question comes up a lot, and people are trying to understand different types of masks. How do I wear them? Are the ones with the little air vent effective? Is that counterintuitive to what we're trying to accomplish? And so I think this is an interesting question that somebody asked also over on YouTube for us. How about a face shield, either with or without a mask? And I don't necessarily know that most laymen have face shields sitting around, but maybe they do. And maybe Dr. Kelso, is that something that you're recommending people have, or maybe in what situations would you recommend that?
Yeah, that comes up a lot. In a healthcare setting, the use of a face shield is really healthcare workers need to not only protect their nose, but also their eyes from possible transmission through the membranes on the eyes. And so the personal protective equipment for healthcare workers includes either goggles or face shield to prevent splashes from getting into the eyes. For the general public, in a non-healthcare setting, a cloth facial covering is better, because the whole idea is it needs to keep your droplets in. If you're talking or clearing your throat or sneezing, you want to keep those droplets in so they don't spread out 6 feet and be able to infect someone else. And a face shield can be somewhat effective at that, but the face shield is open at the bottom. You know, it's the transparent thing over the front of your face, but it's open at the bottom. So as you're talking, those droplets can get out the bottom. Having said that, though, for a child care provider working with infants, for example, it may be more appropriate for that child care provider to wear a face shield than a mask, just because of the perception of the baby, or not wanting to scare the child. So I think there are settings where they're acceptable as an alternative, but a cloth face covering is, we think, more protective.
And there was a great comment by Dr. Andy Rosenfeld last week when we were doing a discussion about helping children transition and their mental health. And there was a comment made that really smiling with your eyes, there's a lot of communication that can be done with eyes. And so maybe with children and modeling that and really thinking about smiling with your eyes, I thought was really insightful. I want to come back to the questions, but I also do want to share an opportunity for everyone tonight who are participating in this webinar. We want you to continue to learn, and you hopefully have learned a lot with us this evening from Dr. Kelso and Dr. Carney. And we have a digital badge, a learning opportunity to show your credentials for what you've learned tonight. This is a Learn and Earn digital badge for participation. There's a little bit of information as to what you can do with those badges, and Kelly will put the link up into our comment box. And then we'll also, when we send out the recording to everybody that's here tonight, we'll include that link so that you can claim your badge for participation, because we really hope you've learned a lot tonight, because I know I always do whenever I have the chance to hear from Dr. Carney and Dr. Kelso. So I want to just come back, because this is kind of a long question. So Dr. Carney, I'm wondering if this might be something that you would think about. The question comes from one of our viewers on YouTube, and it says, I've heard concern from healthcare professionals about a coronavirus vaccine, mainly because they've tried to make a vaccine for coronavirus before and had a response similar to trials for an RSV vaccine, and vaccine admin going fine, appearing to have antibodies production response, but when exposed to the actual pathogen, the virus being much worse for those individuals, in combination with the lack of evidence of its long-term safety. Are these concerns of yours, and what do you think of this? And I don't know if that might be Dr. Carney or Dr. Kelso that may have some interesting feedback on that.
I guess I can't answer that directly. What I can tell you is that there's a lot of different mechanisms that they're trying, new types of vaccines, and some of them are using certain other viruses that are common, and that's a concern in the population. Some are using fragments of RNA that they haven't done before to hopefully stimulate a better immune response. I think that the whole thing with coronaviruses, they are common, and about 4 of them cause about a substantial proportion of the common cold. So I think that people are trying a variety of different kinds of vaccine technology. These will be tested in clinical trials. And as I mentioned, it's really important not to watch what's in the media, but actually to look. And these are showing up in major medical journals now. So I expect that other people are asking these same kinds of excellent and difficult questions, but I don't know the precise answer as yet.
Great.
And I would just add that the trials that are happening now are the phase 1 trials. We need phase 2 and phase 3 trials, and lots of testing to be sure that a new vaccine is both safe and effective. And so it's going to be a while yet before we have a vaccine, if we do have one. And so these social distancing and wearing masks and all these things are going to continue to be important.
Thank you both. Thank you for the science again today, the lessons in past pandemics and what has happened, and the effectiveness of measures that have been taken. And thank you both for your work to help to continue to keep our public healthy and safe. We really appreciate that tonight. Want to just end there because I think our questions are kind of slowing down. We really do appreciate everyone joining us tonight as well on live with us on YouTube. Dr. Carney and Dr. Kelso, thank you again for your time and your insight. We really appreciate it, and please stay safe, and hopefully we'll see you again soon. Good night.
Thank you. Good night.